Well, thank you, Dr. Spear, and I do want to take a moment of kind of personal privilege, and I do want to thank Dr. Lakey. We have seen this conference and the work of the Texas Collaborative for Healthy Mothers and Babies just grow over the years under his leadership and his guidance, so thank you very much. We were thrilled to see the number of people that were here today, so thank you. So I am going to provide, I just wanted to provide a few opening remarks on the behalf of DSHS, and then I think we're going to move into Texas data, and I have the privilege of introducing a couple of members of my team. So Dr. Hellerstadt first, our commissioner, he does send his sincerest regrets for not being here, but as you can imagine, he is attending to some very pressing public health issues back at our office. But it is on his behalf and the behalf of our entire agency that I welcome you to this year's Texas Collaborative for Healthy Mothers and Babies Summit. The Texas Department of State Health Services remains committed to improving the health of mothers and babies. Our own Healthy Texas Mothers and Babies program continues to lead key perinatal quality improvement efforts throughout the state. We provide support to our Maternal Mortality and Morbidity Review Committee and the critical work that they do. We also support the important work of the Texas Collaborative for Healthy Mothers and Babies, including this annual summit. And then in addition, through our Texas AIM initiative and the implementation of maternal safety bundles in hospitals, we are making great strides toward improving the quality of care for mothers in Texas. And I would ask, if you are participating in Texas AIM, could I see a show of hands? Wow. Thank you. Thank you for the work that you do. Thank you for your ongoing commitment to the mothers and babies here in Texas. We know that none of these quality improvement efforts would be possible without support and partnership at the local level. Local participation is absolutely critical if quality improvement efforts are to succeed. So thank you for being here, thank you for your ongoing partnership, and thank you for helping us to improve the health of mothers and babies here in Texas. So with that, I'm going to actually have a couple members of my team. They're going to come up and they're going to actually talk about some of the different data here. First is going to be Dr. Michelle Cook. Dr. Cook is the Director of Maternal and Child Health Epidemiology, and I believe she's going to be sharing with you some of the data from our Healthy Texas Mothers and Babies data book. This is a data book that our group has been publishing for some years now, and it's a really great source of information as it relates to the data associated with maternal and infant health outcomes here in Texas. Then coming to the stage is going to be Julie Stagg, and Julie is the manager of our Healthy Texas Mothers and Babies branch, but she has been with maternal and child health I feel like from the beginning, and she has led some of our very successful initiatives, including Texas AIM, and we are very excited that she's going to be able to share today some of the data from the work that we've been doing in Texas AIM across the state. So with that, I'm going to turn it over to Dr. Cook.
Hopefully I'll be doing this correctly. Good morning. Today, Julie and I will be giving a brief update. There we go. Good morning. Today, Julie and I will be giving a brief update on the health status of Texas mothers and babies in Texas. The objectives of this presentation are to identify and describe key aspects of the Healthy Texas Mothers and Babies Data Book, to review the regional analysis of maternal and infant health in Texas, and to describe the current progress of Texas AIM hospitals. There we go. The Healthy Texas Mothers and Babies Data Book provides an overview of maternal and infant health in Texas. The trends and disparities in infant and maternal health outcomes highlighted in this report can help programs and policymakers make data-driven decisions about how to improve these outcomes in Texas. The data book is not meant to repeat results found in other places, but rather it is meant to bring different data sources together to be analyzed and reported in a way that creates a cohesive view of the status of both infant and maternal health in Texas. The birth rate in Texas continued to decrease in 2018 after remaining stable from 2011 to 2015. Texas has the 5th highest birth rate in the United States. In 2018, almost 390,000 babies were born in the state. In comparison, the United States birth rate has also been declining, but is lower than that of Texas. As in the United States as a whole, Texas has seen a shift in the maternal age of women giving birth over time. The average maternal age at birth in 2017 was 28.1 years of age, a significant increase from an average age of 26.1 years of age in 2009. In 2018, the Texas infant mortality rate reached a historic low of 5.5 deaths per 1,000 live births. The rate in Texas has been at or below national rate for the past 10 years. Moreover, since 2011, the state has consistently been below or exceeded the Healthy People 2020 target of 6.0 deaths per 1,000 live births. However, racial ethnic disparities in infant mortality rate have persisted in Texas, and it is clear that the overall decrease in rates observed in Texas over the past decade was not equally distributed across all race ethnic groups. Infant mortality rates for Black mothers have been twice as high as the rates of white and Hispanic mothers over much of this time frame. Differences in infant mortality rates also exist by maternal age. In 2017, a higher rate was observed among young mothers less than 20 years of age than among mothers of any other age group, followed by mothers aged 40 years and older. Mothers in these two age groups comprised of 9.9% of all Texas resident births in 2017. Severe maternal morbidity, or SMM, is closely related to maternal mortality because it involves conditions that, if left untreated, could result in maternal death. SMM rates in the United States has been rising in the past decade. According to data from the Texas Hospital Inpatient Discharge Public Use Data Files, the SMM rate in Texas remained relatively stable between 2009 to 2018. However, over the past 10 years, Black mothers had higher rates of SMM than mothers of any other race ethnic group. Blood transfusions were the most common SMM condition during 2018. Other common SMM conditions observed in Texas included disseminated intravascular coagulation, acute renal failure, hysterectomy, adult respiratory distress syndrome, and eclampsia. When looking at combined 2014 to 2018 SMM data, there are clear geographic differences in the rate of SMM. Many counties in South Texas and North Texas had a higher SMM rate than the state average. The regional reports provide a comprehensive analysis of key maternal and infant health outcomes, as well as related risk and protective factors in each of the 8 public health regions in Texas. The findings are critical for informing evidence-based practices, the Healthy Texas Mothers and Babies Initiative, and strategies for building and implementing regional coalitions, whose mission is to design and implement public health interventions to meet the maternal and infant health needs identified. Just one example of what we provide in these analyses. This is Public Health Region 1. Not sure if anybody is from that area. But it's a summary table that we provide in the regional report as it relates to key indicators and a 10-year trend with comparison to Texas overall. Lastly, just so you have the data, because we were only given 15 minutes to present, and there's a lot of data out there. Here are the 2 web pages that you can find both the regional reports and the Texas overall report. Now let me turn over the presentation to Julie. I do believe you guys do get the slides, so but for those who want to take a screenshot, I will be passing it on to Julie as you guys take a picture of that.
Thank you, Michelle. Woo, I feel like a rock star with those stage lights. Hello, everybody. Thank y'all so much for being here. I know Dr. Hall had Texas A&M teams raise their hands, but if you wouldn't mind just standing so we can feel your presence in the room. If you're a member of a Texas A&M team, Woo. Thank y'all. So I'm here to share some highlights of some of the progress that our Texas AIM teams have been making over the past, actually through the first year of their implementation of the bundle. And we are winding down right now the obstetric hemorrhage bundle. We're in the action period 3, so the final stage of this learning collaborative, although of course the work will continue. So I wanted to start by giving you a little bit of a background about what Texas AIM is. The DSHS Texas AIM program is Texas's implementation program for maternal safety bundles that are put forth by the National Council on Patient Safety in Women's Healthcare and the Alliance on Innovation in Maternal Health, which is administered by ACOG through a grant from the Maternal and Child Health Bureau, which also funds our programs at DSHS. These bundles are collections of patient care practices and strategies that, when implemented together, are shown to improve maternal health outcomes. In Texas, our focus right now is driven by the work of our Maternal Mortality and Morbidity Review Committee, and is focused on, and by their findings, and is focused on the obstetric hemorrhage bundle, severe hypertension in pregnancy, and obstetric care for women with opioid use disorder, which is a new bundle that is just now being tested in states across the country. As we launched this program at the beginning of 2018, we set forth these goals to accomplish, and we have exceeded many of these. So with 97% of hospitals now participating in Texas AIM, we've surpassed our goal of obtaining participation of at least 75% of hospitals in Texas with obstetric services. The vast majority of these teams, or of these hospitals, are participating at the Texas AIM Plus level of participation, which means that they're sharing strategies and borrowing strategies from each other through a learning collaborative to accelerate their improvement within their local settings. The program supports hospitals with tools and technical assistance through the Texas AIM operations team, the volunteer faculty, and our partnerships with partners including Texas Hospital Association, as hospitals implement bundles using quality improvement methods. And through the Learning Collaborative and from the support of key partners across the state in implementation, we continue to develop and align infrastructure and resources to improve maternal safety through Texas AIM to meet the Texas AIM goals. The 218 hospitals that participate in Texas AIM represent more than 373,000 births per year. That's 98% of Texas births, or almost 10% of the births in the nation. The hard work that these teams that stood up, and many more across the state that are not here with us today, is having a meaningful impact, not just on the patients that those hospitals serve on a daily basis and the families of those patients, but on their communities, their region, the state as a whole, and have the opportunity to have an impact at a national level. Hospitals are making a difference right now through implementation of the obstetric hemorrhage bundle, and that will continue to build on their current efforts with the hypertension and opioid bundles in the coming year. AIM bundles include practices that are designed to increase hospitals' readiness to respond to urgent safety issues that may occur during the delivery stay, to recognize and prevent worsening conditions, to provide standard responses to obstetric emergencies, and to continuously learn and improve through reporting and systems learning. I want to take just a few minutes to highlight some of the improvements made by participating hospitals in the first year of implementation of the obstetric hemorrhage bundle. So on this slide, you are seeing changes in the first year from before the implementation of the bundle until through August of 2019 related to readiness. So one component of readiness for hospitals is to ensure that units have all the necessary equipment and supplies to respond to an obstetric hemorrhage ready, nearby, on hand, and in place in case of an emergency. As we launched this initiative in the summer of 2018, 65% of hospitals already had something like this in place, usually a hemorrhage cart on the unit that is always stocked and ready for use. Within a year, that had increased to 97% of hospitals, which is a 50% improvement. An important component of recognition of hemorrhage is use of quantitative and cumulative measurement of blood loss throughout a delivery and through the recovery period, or QBL. This allows for teams to be able to identify early a potential hemorrhage and to react and respond either to prevent or to control the hemorrhage. At the beginning of this initiative, about 78% of hospitals had not begun to adopt QBL methods. About 16% were beginning to work on this, and about 7% had this fully in place. As of April 19, nearly 80%, or about 80% of hospitals are either working to implement this or have it fully in place. And the proportion that have it fully in place, starting at that 6.6% and now at about 39%, is a 488% improvement. And so by April of last year, the percent of hospitals that had not yet started implementing QBL had dropped from 78% to only 19%. And most of these hospitals, if not all, have started to begin since that time. So once a hemorrhage is detected, it's important to have a policy and procedure to hardwire standardization of a response, and a stage-based response to an obstetric hemorrhage should be a system for a stage-based response for an obstetric hemorrhage should be in place. At the beginning of this initiative, 36% had a policy in place that did provide a standard for stage-based response, and including checklists. And this has more than doubled in that first year of implementation to 77%. And then finally, as an illustration of reporting and systems learning, is debriefing after any hemorrhage event. Effective debriefing soon after a hemorrhage event facilitates care team communication, learning, and incorporation of improvement into future performance. It's an important component of reporting and systems learning, and is essential to long-term sustainable improvements in patient safety and care. The percentage of hospitals with a process for regular and formal debriefs has more than doubled since Texas AIM was launched, with more than 3/4 of Texas AIM hospitals now having systems in place to debrief after a hemorrhage event. So these are just a few highlights to begin to communicate the vast amount of effort, hard work, and improvement that's been made possible by the teams in this room and other teams across the state to bring these practices to full scale within their units. And as they continue to bring those to full scale and work to sustain those gains that they've made, then we'll also be working to add new bundles to this progress. Experience from other states tell us that we can expect to see improvements in severe morbidity associated with hemorrhage in the future based on these new processes. So please join me in a round of applause for the Texas AIM teams across the state who are committed to making healthcare safer for every mother. Thanks to all of you.
Sorry, you sat down heading too quick. I think we have time for a few questions. If anyone has any questions for Dr. Cook or Julie.
Hi, this is Eugene Toy. I have one question and then one comment. When I noticed the denominator for the severe maternal morbidity, it's per 10,000 hospitalizations. I think that's a CDC definition. How does that compare, because we use maternal mortality per 100,000 live births? And I think that WHO uses another denominator for their severe maternal morbidity. I forgot if it's per 1,000 or some other. Just kind of trying to figure out if we translate, or has anyone translated the number of severe morbidities to mortalities. I know that it's usually like 100 or 150 near misses to an actual death, and then how we're doing worldwide regarding morbidity. That's just the comment, or the question, sorry.
We have taken a look a little bit at SSM as it relates to mortality. I don't think have the exact calculations that have been completed, but it's something for us to look at.
We have long used, am I not on? I am. So we have long used those denominators in the data book. We have, I think, have long-standing reported severe maternal morbidity per the 10,000 hospitalizations, and then also the maternal mortality rate the way we've done. And I think those have been kind of the standard way in which we have reported them historically.
Great, thank you. And the comment that I have is, I just want to make sure that the audience is aware of how fantastic Texas really is doing. And because I go to various places in the country, and everyone's asking, how are you doing it in Texas to where you have more than 95%, right, participation in AIM? Yeah. And so, you know, we have to figure out who those other hospitals are and get after them. So if they're in your neighborhoods, tell them we got to get to 100. But truly, because it takes a lot of effort. This is not easy. QBL takes effort. The physician side, the nursing side, and the hospital. So, you know, I think we really, really have to recognize the leadership from our collaborative. So Dr. Hall, Dr. Lakey, and others, and then also Dr. Spear and Dr. Pat Ramsey, and missing a lot of people I know, and the perinatal, the RACs, but also the hospitals, and the Texas Hospital Association has been amazing. So I'd like to just have everyone stand up and really applaud the leadership at yourselves and your hospitals as well. Can we just stand up and then just kind of really acknowledge the great work everyone's done?
Dr. Toy, thank you for that comment, because, and again, thanks to the hospitals, because the leadership across this state for this effort, I can't stress enough how critical it is, and none of this, I mean, the hospitals are the collaborative. The leadership is coming from the hospitals, and the learning, the knowledge is held within the hospitals. So all we do is bring folks together and facilitate that sharing, the expertise that exists all across the state to make this change happen.
And I'm going to take a point of personal privilege, because Julie is up here on the stage, who has been instrumental in kind of spearheading this effort, but so is Dr. Carrie Epps, who is the chair of our faculty. She also happens to be one of the co-chairs of the Obstetrics committee here at TCHMB, so she has a leadership role in many areas related to Texas AIM and the collaborative, and we greatly appreciate all of her work and her efforts. Thank you.
I think we have time for one more question.
Thank you. Thank you so much for this. I think you're selling yourselves short a little bit, because this takes more than a village to actually put in place. I just think, Julie, can you share with the audience the work that was just completed this past week? Because I think that it didn't touch everybody, but if we could replicate that and make it be just part of standard of how we teach and learn and engage, it would be wonderful.
Yes,
Thank you.
thank you for that, Linda, and thanks also for hosting one of the events. It was wonderful. So we had, over the past 2 weeks, we're able to convene 5 training of the trainer simulation trainings across the state. And we're still finalizing the numbers, but we had about 150, probably a little more than that, hospitals participate in that, sending a training team to that, and then also through a partnership with our Johns Hopkins University and Agency for Healthcare Research and Quality to do a training of the trainer on some team steps work as day 1, and the simulation on day 2. Dr. Shad Deering helped or led that training, as well as and Dr. Carrie Epps and a slew of fabulous volunteers who with expertise in simulation. And then all of those hospitals sending for 2 days a physician lead, a nurse lead, and often an educator or their maternal levels of care coordinator to this training to have hands-on skills training with how to run drills on their units, and it was a really fabulous effort, statewide effort to make that happen. And it will make a huge difference, I think, in what they bring back to their hospitals and implement in those settings to continue to accelerate these changes that they're working on. So thanks to all of y'all for that.
Thank you. Now, there allegedly is someone that's supposed to be a moderator for my session, but I'm perfectly happy to introduce myself.